I'm Dr. Emily Silverman, and welcome to Talking Dementia with Remo Health. Join us as we explore the latest advances, insights, and strategies that help empower those living with dementia and the families that support them. Each episode, we sit down with leading experts, from physicians and researchers to policymakers and clinicians, to provide you with the resources needed to navigate this complex disease. Today, we're speaking with Dr. Cheryl Phillips. Cheryl is a nationally recognized expert in geriatrics and health policy. She's the former CEO of the Special Needs Plan Alliance and now serves as a senior consultant with the John A. Hartford Foundation's Age-Friendly Health Systems Initiative. A fellowship-trained geriatrician, Dr. Phillips has led major efforts in Medicare Advantage, special needs plans, and long-term care. She's a past president of both the American Geriatric Society and the American Medical Directors Association, and regularly advises federal agencies on elder care policy. Cheryl, thank you for being here today.
And thank you, Emily. My pleasure.
So Cheryl, you began your career as a geriatrician. Tell us what you learned from caring directly for older adults and how that shaped your understanding of dementia in your earlier years.
Well, thank you, because that is a very important question. Geriatrics is not the study of just disease. Older people are not the sum of their diseases. They are, in fact, just like you and I, in the context of their families, of their lives, of their situations. And so being able to start that journey with an older adult and their family or care partners meant that you were looking at the whole person. To me, that is the richest pleasure about geriatrics, but it also means a lot about the care of dementia and individuals with dementia. Because just as we started, those individuals live in the context of their homes, their family units, if they have them, or their care partners, however they define them. It is often these care partners and family members that first recognize subtle changes as a precursor to a dementia diagnosis. So for me as a geriatrician, understanding the role of the family, their caregivers, and the person in that holistic context is critically important before we start getting into diagnoses and medications and all of the medical milieu that we bring forth.
And as a practicing physician, what is it that made you interested in getting into leadership and systems? We're going to talk in a minute about moving to Onlock, which is where you held a leadership position. But I'm wondering, is there anything specific that you saw or you noticed in your practice, gaps or ways that the system was failing to meet the needs of families that inspired you to move into policy and systems practice?
You know what? It actually was way before medical school. When I was in elementary school, my mother worked in a nursing home. And I came after school, and several observations that I had. One was that most of the people were very, very lonely. And one of the women, and I will say as a 10-year-old, she became my best friend, and I'll call her Mrs. B. Mrs. B was blind. She lived alone. She was a diabetic. And so back in those days with insulin, she had to be in a nursing home. But every day I would meet Mrs. B. I would read my homework to her. I would interact with her. She was my best friend. I saw her on a Friday. I came back on a Monday and there was somebody else in her bed. And I asked the nurses what had happened. And they rather nonchalantly said, oh, she had died over the weekend. And I asked where her things were. And they pointed me to a large garbage bag where they had put all of her belongings. And I remember at the age of 10 thinking, we're not doing this right. Not only was I grieving for my friend, Mrs. B, but I knew that we had to create a better system of care for addressing the needs of older adults, not just the medical needs, but the whole person needs. So when I went to medical school and residency and my geriatric fellowship, I actually went with the mindset of, yes, I want to be an excellent clinician and I want to take care of patients, but I want to look at the systems of care of how we end up caring for patients and their family units.
So what was it exactly? Was it the fact that her belongings were in the garbage bag? It felt in some way that she had been disposable?
She was disposable, but nobody seemed to care. Nobody was really sure what day she died or why. There was no engagement. And I am not disparaging the workers because this was in the 70s. They were understaffed. It was a challenging time for them as well. But I was very observant that this didn't seem like a good place to live. This was not where I would want to be, or I would want somebody that I loved to be. While that story typified my emotional response, the bigger question was, how is care delivered for the Mrs. B's?
Wow, so you got into this topic at a really young age.
Without knowing what it meant or what the journey would be. But yes, and I had had some other career paths because I hadn't been destined to go into medicine. I actually was a microbiologist. And when you're bored and you don't know what to do and you're a microbiologist, go to medical school. So there was my journey. And I really didn't know anything about public policy. I didn't know how to influence. I didn't know what a role was. And I think for many people, even family members who think that you have no voice in public policy, recognizing that even starting at a local level, expressing concerns when they arise, writing comments. So my journey was very incremental with that same sort of mindset of start local and then spread.
Well, tell us about your time at OnLock. You were chief medical officer there, I believe, and OnLock was the original PACE program, PACE, which stands for Program of All-Inclusive Care for the Elderly. Tell us what that is, and then tell us what it was like to be a leader in that space.
Oh, I am delighted to do that because to me, the PACE model, Program of All-Inclusive Care of the Elderly, really is the ideal model. And yes, it did start in OnLock in San Francisco. And OnLock means Peaceful Happy Garden. It started in Chinatown in the late 70s and then moved into a formalized model in the 1980s. And the intent was that older folks living in both the North Beach and Chinatown areas, because there were no local nursing homes, would be sent out of the area, often far away from their families. In the case of those in Chinatown who were Cantonese speaking, into nursing homes that didn't speak their language. So OnLock was originally formed to serve this population as a nursing home alternative. It is now replicated in 33 states and the District of Columbia here in Washington, D.C., where I am. It serves about 95,000 people. And the criteria are that you are 55 or older and that you are at a nursing home level of care determined by the state. That's a fancy way of saying that you need some help with dressing, with feeding, with getting to the bathroom, etc. But the program's intent is to keep you as independent as possible. And it does that by blending both the Medicaid services and all of the medical services that are covered under medical care. So there's doctors and nurses, there's dentists, there's foot doctors, all of the medications, there's home care teams. It is a complete, comprehensive package of care that is very team-based. And what I mean by team-based is there's social workers and drivers and therapists and doctors and nurses. But the person is at the center, the person and or if the person is unable to speak for themselves, the family member or care partner. So in the PACE program, we don't call individuals patients. We don't call them residents. We call them participants because they are at the center of the care. So it is integrated, to overuse that word. It is blended payment from both Medicare and Medicaid. But most importantly, it is the whole care approach to the person for the rest of their lives as an alternative to nursing homes. Now, some people do end up needing 24-hour care in a nursing home, and the PACE program continues to follow them. So that's kind of PACE in a nutshell. As you can imagine, there are a lot of PACE participants that also have dementia. And so having that whole person approach to dementia care is critically important in the PACE model and program.
Is the goal of the program, or one of the goals of the program, to help participants age in place, age at home, or does it work having them in assisted living facilities and things like that?
The goal is to keep the individual as independent as possible. Now, for some people, it is living at home and it's with wraparound services, and it allows the family, frankly, to not have to do all of the coordination and all of the managing of appointments and transportation. But for instance, when I was at Onlock, we had a lovely participant who was non-ambulatory, but she lived on a third floor walk-up with no elevator. So for her, living in her apartment really wasn't a safe option. So we did find assisted living. So many times, PACE participants will move to a congregate living setting, but again, the goal is to keep them as independent as possible. And the PACE program brings them into the PACE center that has therapies, it has activities, there's congregate meals, there's the clinic. So there's a lot of social interaction. People don't come every day. They will come based on a schedule that they and the team agree upon. But there's so much more to the PACE program that, again, goes back to the whole person.
You mentioned that a lot of the participants in the PACE program were living with dementia. And I was wondering, as a geriatrician and as somebody who knows a lot about these different systems and programs, how do you think differently about our elders who are living with dementia? Obviously, dementia is a really broad catch-all term for many different diseases. Some of them very, very chronic. Some of them can happen and accelerate more quickly. But just broad strokes, how do you think about that patient population, and why is that all-inclusive, wraparound, holistic approach so important for that population in particular?
When we think about dementia illnesses, and again, as you mentioned, that's kind of an umbrella term. I think many of the listeners will think about Alzheimer's, but there's other kinds of dementia. We often put it in a medical box, and then we think about what medicines are we going to use. But what we know, the real effective treatment for dementia is that supportive environment that keeps the person engaged, that keeps them socially active, that helps to stimulate them, whether it's music or walking or interactive games, that there is still that whole person approach. And I will add to that, that very often in the medical environment, once person is diagnosed with dementia, we tend to not talk to them anymore. We think that they don't have a voice. And so we talk to other surrogate voices. But in good dementia care, that person remains central. We're talking to them, we're listening to them, even if their actions or behaviors may be negative at times, they're trying to communicate something to us. So good dementia care allows that person to be in the center and the supporting team around them to keep them engaged and social. That's what works effectively in the PACE program. It's also what works effectively in good settings of care that understand dementia care. Now, just because something says it's a memory care center doesn't mean they do all of those things in a good way. But good, effective dementia care really reflects on the understanding the whole person and interacting with them and allowing them to communicate in the ways that they can.
Since you said that just because a place calls itself memory care center doesn't necessarily mean that they're well equipped, for families who say, oh, it's a memory care center, it must be great. Like, what are some of the things that they should be looking for to know if it has indeed the resources that we would all want our loved ones to have?
I often have this conversation with families when they've made a decision that mom or dad or their spouse needs to go to a congregate setting of care, and they look at these memory care places, and some are excellent and some are not. And they will say, how do I tell the difference? So my advice always starts with use your senses. Walk into the environment. What does it look like? Are people interacting? Are staff engaging with the residents, or are the residents sitting in a chair by themselves or stuck in front of a TV or back in their rooms stuck in front of a TV? So what are you seeing? What are you hearing? Is there friendly interaction, or are you hearing lots of crying or yelling out because people are off in corners and not attended to? What are you smelling? I kind of know what we're looking for there, but does it smell fresh? Is it a comfortable environment place, or does it smell musty, or dare I say, even smell like urine? So as you walk in, you get this sense. Don't let the chandeliers in the front lobby fool you, because most memory care centers have lovely lobbies and beautiful chandeliers. Walk back to where the people are and watch how the staff are interacting. Do they call them by name? Do they interact with them as they walk by? Are people actively engaged? The next layer is I would ask the administrator or the leader, tell me about the training that you give your staff for caring for dementia, because it is a very special skill set. It's not just passing out food or medicines and wheeling people around. How do you react if that person is upset and angry? How do you react if they are asking the same question over and over and over and over again? How do you react if they're trying to leave? Because wandering and trying to leave is not an uncommon behavior. So, how they answer those questions and how they train their staff, to me, is another key element. And then just go with your gut. If you feel comfortable being there, odds are your loved one will as well. If you are not comfortable, your loved one's going to pick up those same vibes.
I love that response. It's one of the most simple and clear responses to that question that I've ever heard. So thank you for that. I do want to move on and talk about the Special Needs Plan Alliance, because I know that's been a really big part of your work. So this is a national organization focused on people with significant care needs. Tell us about this alliance. What is it, and what did you do there, and what did you learn there?
Well, I'll back up a little bit, because I think it's important just to say what are special needs plans. So special needs plans are a subset of Medicare Advantage. Your listeners may think of these as Medicare managed care. But we know that Medicare managed care, where they may have 100,000, 500,000 members in the health plan, everybody is not the same. And those with complex needs, and we'll talk a little bit about that, often get lost in those plans. So these plans were created in the early 2000s, and I won't get too wonky for your audience, but there's three types. One is if they have one of the 15 chronic serious conditions. So we think of heart disease and diabetes and lung disease and cancer. But interestingly, dementia is also one of those categories for a special needs plan. The second is if they are at, we call it an institutional level of care. You recall when I talked about the PACE program, are you eligible for a nursing home? That's the institutional level of care. But that doesn't mean you have to be in a nursing home. You could be in a nursing home, or you could be living, for instance, in assisted living or in another setting. And then the third type, for those who have Medicare and Medicaid, so lower income individuals. Now, within those three groups of these special needs plans, there are a large percentage, and it varies by the plan type, that have a dementing illness. Now, why did I go in there? Because here's a geriatrician who's used to taking care of frail older adults. And now I was running an association of insurance plans. But here's why, because my belief is that in order to really provide the best model of care, you need to integrate, you need to blend, you need to pull together the payment, so the health insurance, the regulations, and the delivery model, or how you take care of people. So going back to my PACE and Unlock experience, which blended all of those, when I look at health plans that have the ability to work much more closely with a care team, with doctors, nurses, social workers, so they can blend the payment, the regulations, the rules that they have to follow, but the delivery model that can best serve that population. So that's why I went into the SNP Alliance, and I was very proud to work with some really remarkable health plans that are doing some exceptional things. But I will add one thing here. Hardly any of them focused on dementia. That's an opportunity for us to think about why. Because the health plans are typically looking just at the medical costs. But I know that our listeners can say, and I can even speak out of my own experience with my mother with dementia. We spent close to $70,000 a year in care and various things that we paid for that was not covered by Medicare. So when the health plans are just thinking about the medical costs, what they're really missing is all of the support needs that the person has that fall outside of the medical costs. That is one of the big opportunities that I hope we'll have a chance to talk a little bit more about.
So, a medical cost would be something like, for example, what is the cost of an MRI?
Yes, or a hospitalization or an emergency room. And this is where it's kind of sneaky because we know that individuals with a dementia illness end up spending more in medical costs. But the tricky part is they don't go because of the dementia. They go because their heart failure got worse because they weren't able to manage it. They go because they fell and they have an injury. They go because they are not eating well, they decline, they get a pneumonia. There's so many hidden ways that dementia impacts the medical costs, but the hospital systems and the health plans often don't see that because when the individual goes into the hospital, if you look at the chart and the diagnosis, it will say pneumonia or hip fracture or heart failure, not that Esther has Alzheimer's disease and therefore has been declining. And because of that, then these other things happened.
This might be a nice moment to talk about GUIDE, which my understanding is this is a different way of thinking about payment in dementia care. Can you tell us about GUIDE and how that factors into what you just said?
I'm delighted to talk about GUIDE. So for many years, we have been expressing the need, as I started out by saying that dementia care is a whole person support system. And so the Centers for Medicare and Medicaid Services, commonly known as CMS, they're the ones that manage Medicare. They have come up with this program, really a pilot, a study, to look at how the big picture of care for individuals with dementia, particularly supporting family and care partners across a continuum can impact overall costs of care and outcomes. It is available at no cost for people, but it is intended for those who are on what we call traditional Medicare, not Medicare managed care. But I'm going to get to that in a second. So this program has identified clinical teams that are partnered with social workers and support systems. And there are about 300 plus of these units around the country, these provider groups that will enroll individuals with dementia and their families. And so it's a continuum program that most importantly, I think, focuses on diagnosis and on 24/7 support for caregivers. Because when caregivers have issues and questions, they need them when they need them. I'll do a little bit of a sidetrack here, a bit of an anecdote. So I started a program in a hospital system in Northern California for dementia care. And this was back in the 90s, and we weren't yet really doing the coordinated models that we are now. And so when the individual would be enrolled and their family would come, we would give them 3 big binders because we were being so helpful, because we were giving them all the information we could think of, except it was useless to the family members. They didn't want 3 big binders. One person told me, I don't even know where to store these. What am I supposed to do with them? And I think the best answer that somebody gave me was, I need to think of help like pizza delivery. I don't want 6 pizzas that I put in the freezer. I want one when I'm hungry. So I need help when I need it. And that's the intent of Guide. Now I'm going to move a little bit because remember I said it was for traditional Medicare, not managed care Medicare. So many health plans said, oh, well, this isn't for us. We don't have to do it because there's no extra money for us. So part of our work now on the policy side is to point out that in fact, health plans, one, are already getting paid to take care of people, including with dementia. And as I mentioned earlier, they're already spending money they don't know about. So how can we think about taking the Guide support services and move it into managed care? And Remo Health is one of those examples of how the health plan can then say, we have, let's say, 1,000 members that have a dementia diagnosis, but we don't have the ability to do all the support and the education and the care coordination that the family or caregiving units can do. So we're going to partner with an organization like Remo Health to be our partners in that journey for the individual.
So let's see if I can get this right. Instead of a cash register for an MRI, cash register for a hospitalization kind of approach, they identify interdisciplinary teams that are providing on-demand care, like a pizza.
Like a pizza when you're hungry.
To families when they need it. And they're partnering with those organizations to reimagine the way we do reimbursements for that care. Does that sound right?
Exactly. And then avoiding some of the costs that they weren't recognizing were related to dementia, the emergency room visits, the falls, the not eating and poor nutrition leading to frailty and pneumonia, and all of the other things that were less obvious to the health plan. And at the same time, you now have a family that is better supported, an individual who is better supported, whose journey through dementia becomes not easy and not perfect and not without loss and heartache, but at least with a supportive team behind you to help guide you. I'm going to add one other point that this partnership is so very important. Remember, I mentioned there are about 300 plus sites of care that are Guide recognized. But what happens if you live in the middle of nowhere? What happens if you are 4 hours away from one of these sites? Having something like a Remo Health allows for that access of education and 24/7 support, even when the family and the individual can't get into these dementia care centers that are around the country. And I think recognizing the needs of rural health is increasingly important.
There's a term that goes around a lot that's called value-based care. How does that connect with dementia care, guide, Medicare, Medicaid? What does that mean in this context?
Sure. I smile a little bit because it is a term that's used, shall I say, generously. And as I dissect it, its value for whom and what is the care. So, in an ideal model, value based care means that I am improving the quality and I am reducing unnecessary costs or services. So, for example, if I have heart failure and somebody is helping me manage my heart failure, I am less likely to go to the hospital. So, a value based care model implies that, yes, I'm saving the hospital money, but it's because I'm getting better care. So, in a true value based care partnership, we're looking at what are the costs that we want to avoid, not to withhold care, but costs that nobody wants to spend money on because I don't want to go to the hospital for my heart failure. And the hospital doesn't want me there if I don't have to be there. But in order to do that, I need to have a care model, a care system that helps me so that the emergency room isn't my only source of support. And that's kind of a complicated way of explaining what value based care is. But to an insurance plan, for instance, a value based care partner would be someone that says, hey, I can save you avoidable costs that nobody wants, and I can improve care outcomes. And maybe I can share the way that we will pay for this is you give me a little percentage of that. So we have a shared risk arrangement. That's the way most value based partnerships are based. So you pay me to do this care, which is going to cost less than what you're paying right now. And the individual is going to get better care. And I think in most languages, that would translate to win, win, win.
We've talked a lot about medical care and assisted living and all of the different services that are required for people living with dementia. But with dementia, one really important element of care is empathy. It's such a difficult disease process because it affects the brain, and the brain is kind of like where we are located, and it means things about who we are and our personality. And that's one of the things that makes it so hard for families is they feel that their loved ones are changing, like their essence, their personality is changing, and can cause, I think, just a different quality of emotional distress compared to a disease like heart failure or cancer. And this comes out in a lot of the symptoms that people have, behavioral symptoms, things like that. And so I'm wondering what you think about empathy as a service. How does the healthcare team, whether that's a doctor or a nurse or a social worker or a pharmacist or the 24/7 hotline operator, how do we think about infusing that empathy and that compassion into the care itself, because it is so needed?
Well, first of all, I will start out with an amen, because true dementia care, and I mentioned that in the beginning of our conversation, it is looking at the whole person. So empathy comes from, I'm not just sorry for you, that's sympathy. In empathy, I'm trying to understand as much as I can all about you and what you're going through. And that empathy is equally important to the family and care partners because they are going through a journey as well. I do believe it is absolutely at the core of most of our human interactions, but our workflow, our processes, our charting, our billing, the sites of care, All of those get in the way of that core empathy, the ability to just stop and say, you look like you're very distressed. I know it's hard to find words, but can you just share with me what is making you upset right now? That's empathy, and that takes a pause. What caregivers on the medical side will find, so nurses and nurses' aides and physicians, that when they use empathy, actually the rest of the care goes better. So empathy to me is starting with understanding. And in the best dementia programs, that's where when I said, how do you judge a memory care? Just walk around. Do they have empathy? Are they caring? Are they interacting? Do they stop and listen to people? So I will give a little story about the lack of empathy and how it played out and how we had to learn a lesson. This was a nursing home that had a memory care unit, and there was a gentleman who kept tripping the nurses and hitting the nurses, and they wanted me to give him a medication to calm him down. When I walked into this nursing home and the activity center where he was, there was somebody pounding on the piano, there was a radio going, and there was a parrot squawking. Why they had a parrot there, I do not know. But they had a parrot squawking in the corner. And I asked the nurses, what do you do when, we'll call him George, strikes out at someone? Oh, we take him back to his room, and then he calms down. It didn't take George very long, even with his dementia illness, to realize that if it got too noisy and he was getting stressed out, all he had to do was thwack someone and they would take him back to his room. So the empathy part was we stopped with the nurses and said, what do you think is happening here? What do you think that George is experiencing? If you're him right now, what does it feel like with all that noise? And then you guys put him back in his room where it's nice and quiet. Are there ways that maybe we can interact with George that is more one-on-one, that's quieter, that we don't leave him in the activity room for so long, that if we do, that we're watching him to seeing if it's getting agitated? To me, that's an example of how empathy plays out. And then we could spend all this call on talking about the empathy of the caregivers, the exhaustion, the frustration, not knowing what to do, being able to just stop and listen and say, what matters most to you today? Tell me what's the most important thing that is impacting you today. That's empathy, and that's real dementia care.
Those questions, tell me what matters most to you today, reminds me of this idea of shared decision making. And I was wondering if you could speak a bit about shared decision making in dementia.
Absolutely. So shared decision making certainly involves information to both the individual with dementia, because certainly at the earlier phases, they can be participants in their discussion, as well as the family members and care teams. Shared decision making also doesn't mean that just because I have a diagnosis of dementia, that you quit talking to me, you start talking to my daughter. I'm still part of that conversation. One of the areas where I am doing some work is with the John A. Hartford Foundation in a scope of work called age-friendly healthcare. And it's built on the 4 M's, and it starts with what matters. So to me, it is the essence of shared decision making. We start with what matters to you, the person, what matters to your family. And then we focus on medications, what's helping, what isn't, what are side effects, what are making things worse, mentation. So not only the underlying dementia and understanding that, but are you also having depression? Are you having a medication reaction that's making you even more confused? We call that delirium. And then the last is mobility. And the reason why this is so important is that one of the things that happens with individuals with dementia is we want to make sure they don't fall. So we put them in a chair and we don't let them get up. That makes their dementia worse. That makes their depression worse. That makes their quality of life worse. And then when they do get up, they fall. So mobility also means how do we keep that person as active as safe and as active as possible? So shared decision making to me starts with these 4 questions, starts with what matters, but then it also brings in all of the other medical decisions in the context of what matters. I will give you an example of shared decision making. Now, granted, I am a geriatrician, so I have the advantage of knowledge, but my mother, who was 92 and had very advanced dementia, and she had an infected toenail in her big toe. It hurt her a lot. She winced. She wasn't walking, but every time you take her socks off, she was in pain. I took her to the doc who said, well, we need to do some vascular studies because she has bad pulses in her feet. And that's where shared decision making kicked in because I said, so what would we do with that information? Why would we do vascular studies? 1, we have to move her all over the place. 2, I have to go to another specialist. But then what? Are we going to do surgery? Are we going to do things? And then if we're going to look at her legs, then we got to look at her heart and then we got to look at her carotids for her brain. So all we need here is to take the toenail off. And he said, well, it may not heal. So the shared decision making was, I'm willing to take that risk about the toenail not healing because right now it hurts her a lot, but we're not going to do all the other tests. And I use that example because you don't have to be a geriatrician to ask some of those same questions. Because very often families are handed a list of things we're going to do, and shared decision making says, wait a minute, can I ask why? What are we going to do with the information? How will this change? What are the advantages, but what are the disadvantages? What are the risks for the person that I love? That's shared decision making. And sometimes on the family side, we have to start with the questions why.
As somebody who's very active in healthcare policy, I'm wondering if you can say a word about this particular moment in time. There's a lot of upheaval politically, and this is going to affect people with dementia and their families. You're in Washington right now. What can we expect, and what should caregivers know about what's coming or what might come?
Thank you. And I will try to be as nonpartisan as possible because I don't want this to be a political discussion. On the positive side, this administration says that they are very interested in both older adults and family caregivers. So there may be policies that have some financial implications for family caregivers, and that would be a positive. There's also an interest in expanding the PACE program that we talked about earlier, and so that would be a positive. The negative is when we think of Medicaid, we think of just poor people, not us. We're not Medicaid. It's moms and babies and poor children. Medicaid is the number 1 provider of long-term services and supports, that care unit for people across the country who are older and certainly with dementia. So not only is it nursing homes, but it's also many of the home-based services that people rely on. I am very concerned that with some of these budgetary discussions and the inevitable cuts to Medicaid, even though we're going back and forth, that the places they will cut will be these services because they are the easiest places to cut, because they are considered optional services or add-on services. And so looking forward in the next year or two, one of the things that in many of my roles that we are such a vocal advocate about is Medicaid is older person's care, and it's essential for family caregivers. And if you take away those services, the only place that people can go will be nursing homes. And then it will be like my friend Mrs. B when I was 10 years old, who were in a setting of care that was not the right setting for them, that did not support their personness, That is not the way we want to treat our older adults. So we all have to be quite observant and also quite vocal that the Medicaid cuts are not just other people. They are our neighbors, our older parents, people who need supportive care. And as we look at that going forward, we need to be a strong voice for making sure that Medicaid has those home and community-based services protected.
I feel like we could talk for another hour. I love listening to you talk. You communicate so clearly about these issues, which are obviously very complicated. And I'm sure our audience appreciates you clearing the fog a little bit around some of these policy concepts. But I also want to be respectful of your time. So as we draw things to an end, I was wondering if you could just take a minute and tell us if you had to give any advice or bust any myths or give a final message to people listening. Maybe they're a dementia caregiver, or maybe they're somebody in the policy space. What would you want that message to be?
I'll start with a myth that once people are diagnosed with dementia, that they're no longer important, that they no longer have value, or that they no longer contribute. And that is a myth. And throughout the journey of dementia, that person is still there. I also will acknowledge that it is not easy work for the families and the caregivers. And very often the family caregivers are minimized and thought that they don't have a voice. So the other myth is that you have to be quiet and just try to figure it out. If I could give one message to the family caregivers, it's speak up, look for resources. There are services out there. There are people out there. And most importantly, I will speak from my own experience. It is a privilege and a joy in a very special way to be part of that journey with the person and with their family as they go through some sometimes very difficult, challenging situations, but to be there with them and know that you are part of the team with them so that they are not alone. It's a privilege for me, and I encourage the listeners, find a partner in care.
I have been speaking to the wonderful Dr. Cheryl Phillips, physician and policy expert and empathic human being who is here today to speak with us about dementia. So, Cheryl, thank you so much for coming to speak with us at Remo. We really appreciate it.
Oh, it is my pleasure and honor. Thank you very much, Emily.
Thank you for listening. For more information about this episode, check out the links and resources listed in the show notes. If you're interested in learning more from Remo, visit us at www.remo.health. Take care.